Welcome to the My Favorite Learners podcast, where pharmacology meets real-world anesthesia in a whole new way. Hi, I'm Chloe G. I'm here to shake up how we learn about drugs. No dry lectures, no endless memorization, just real conversations with CRNAs, pharmacology experts, and other healthcare pros who know their stuff. Whether you're a student, a seasoned provider, or just a pharmacology nerd, we're diving deep into the meds that make anesthesia happen. So grab your coffee, your curiosity, and let's talk drugs. Hello, my favorite learners, and welcome back to another podcast episode. If you are watching me, let there be light. I just turned my ring light on, so now there's a little bit more going on if you're watching. If you're not, I hope you're going on a walk and listening to this so that you can get a little bit of review in while also checking in with your mental health, going on a walk, things of that nature. Today, we're going to be talking about serotonin syndrome, neuroleptic malignant syndrome, and malignant hyperthermia, and the differentiation between the three. Last week, we talked about methemoglobinemia, carbon monoxide, and what was the third? I already forgot. Ooh. Cyanide toxicity, of course. And so we talked about the differential diagnosis between the three because those are three things that can be easily confused, especially when it comes down to boards, but then clinically relevant as well. I have a friend here that wants to say hello, a special guest. Want to say hello? You say hello, my favorite learners. Come here, say it right here. Just say hello, my favorite learners.
Hello, my favorite learners.
There we go. If you're listening to this, that was probably the cutest moment on this podcast. Now that we've got the cuteness out of the way, we are talking all things serotonin syndrome, NMS, neuroleptic malignant syndrome, and malignant hyperthermia. So why does this matter? Because all three of these things can look similar, right? They have the characteristics of hyperthermia, tachycardia, autonomic instability, altered mental status, muscle abnormalities. And if you misidentify the syndrome, you may give the wrong treatment, right? You delay life-saving therapy, and the patient could get worse. This is also classic boards content, while also being real-life clinical content, right? Three things, three diagnoses, differential diagnoses that look similar, and we're going to break them down so that you're able to identify them in real life and on boards. So let's go. I want you to organize these into three different receptor problems, similar to how last week we talked about the three being an oxygen utilization problem. These have three different receptor problems. So for serotonin syndrome, we have the core problem being too much serotonin. For NMS, I'm just going to call it NMS because neuroleptic malignant syndrome is a mouthful. I keep messing it up every time. This is where there's not enough dopamine signaling. So serotonin syndrome is obviously serotonin. Neuroleptic malignant syndrome, NMS, is not enough dopamine signaling. And malignant hyperthermia is that release of too much calcium within skeletal muscle. So that's the entire topic in one short little snippet, coming down to three different receptor problems. So for this, there's a quick memory trick, right? So for serotonin syndrome, it is an excited nervous system. That is what we have. For dopamine blockade, we have rigid, slow, and toxic. For calcium flood, we have a metabolic firestorm. So if you know the mechanisms behind each of these differential diagnoses, the signs and the treatment make sense. So let's talk about it in terms of real-life patient care. So let's imagine you're in the PACU. Your patient's temperature is 39.5 degrees Celsius. Heart rate is 138. Blood pressure is swinging high then low. The patient appears agitated, tremoring, and diaphoretic. Now you learn that they take sertraline. They've gotten fentanyl, ondansetron, and metoclopramide. They are now rigid and confused. What is this? What is going on? It could technically be serotonin syndrome. This could be neuroleptic malignant syndrome. I said I was going to use NMS, and here I am saying the whole thing. It could be MH if they were exposed intraoperatively. So let's learn how to separate these three things really quickly. Breaking down serotonin syndrome first. So what is serotonin syndrome? Serotonin syndrome is caused by excess serotonin activity, especially at 5-HT1A and 5-HT1A receptors. This happens when serotonin becomes too abundant or too stimulated. Again, we talked about serotonin syndrome being, drum roll please, too much serotonin. The common causes of this, so what could cause too much serotonin? Antidepressants, right? SSRIs, that's the point of them. We want to increase circulating serotonin. Our SNRIs are tricyclic antidepressants, and our MAOIs as well. So that whole gamut of antidepressants can increase our risk of serotonin syndrome. Our anesthesia-related triggers, right? We have meperidine, we have tramadol, fentanyl, although that's rare, methadone, ondansetron, which can be a possible contributor, again, rare, linezolid, and methylene blue. For boards purposes, the most common risk combo, or a high-risk combo that is high yield for boards types of questions, is an SSRI plus meperidine is very high risk for serotonin syndrome. So SSRI and meperidine are at high risk for serotonin syndrome. An SSRI and tramadol is high risk for serotonin syndrome. And lastly, SSRI plus an MAOI in combination increases your risk for serotonin syndrome. And that is boards gold. Knowing those three combinations can cause serotonin syndrome. The clinical signs, let's talk about what it looks like when a patient has too much serotonin or serotonin syndrome. Onset is fast, usually within hours, but there's a triad, right? We love triads in medicine. And this spells out, it can spell out MAN, M-A-N, would be mental status changes. A would be autonomic instability, and N would be neuromuscular hyperactivity. So the triad for serotonin syndrome spells out MAN, mental status changes, autonomic instability, and neuromuscular hyperactivity. So high yield findings within this triad would be hyperreflexia, clonus, tremors, myoclonus, agitation, tachycardia, hypertension, and diaphoresis. The most important clue here with serotonin syndrome, when we compare it to NMS in particular, is that serotonin has this hyperreflexia and clonus. That is what sets apart serotonin syndrome from NMS. The treatment, like I always say, what is the first step? It's just like an ACLS, right? The first step in ACLS is turn on the defibrillator. Similar thing here. What are we going to do? We're going to stop the offending agents. Stop what we're doing that's causing this. Then we're going to, number 2, supportive care. 3 would be benzodiazepines. Lastly, you can give cyproheptadine for serious cases. And the clinical pearl here is to avoid meperidine and tramadol in patients that take SSRIs. That is the key takeaway here. I'm looking up cyproheptadine. Let me look this up quickly to see how this works with serotonin syndrome. Cyproheptadine is a first-generation antihistamine with important serotonin antagonist properties. It is commonly used and is as an anecdote in serotonin syndrome because it blocks serotonin receptors, specifically or especially 5-HT2A and also some 5-HT1A. This helps reverse the excess serotonin effects causing agitation, hyperthermia, clonus, and autonomic instability. So essentially, the mechanism is that it shuts off serotonin signaling. It also has H1 antihistamine effects and sedation effects in that way, anticholinergic effects, and appetite stimulation. It's mainly used, it looks like, or can be used for allergic symptoms, appetite stimulation or weight gain, and the number one use is serotonin syndrome. Very interesting type of medication. So back to our next differential diagnosis that we can go through as we're comparing the three is NMS, Neuroleptic Malignant Syndrome. So what is it? NMS is caused by dopamine receptor blockade, especially within the parts of the brain as the hypothalamus and the basal ganglia. This causes poor temperature regulation, severe rigidity, and autonomic instability. Common triggers to this syndrome, NMS, are antipsychotics, so haloperidol, risperidone, and other triggers could include metoclopramide, which is our Reglan, right, droperidol, and withdrawal of levodopa or dopamine agonists can cause this NMS, neuroleptic malignant syndrome. The key clinical difference here is that the onset is slow, usually over 1 to 3 days. That is much slower than serotonin syndrome. Okay, classic findings, the tetrad. So with NMS, there is a tetrad. There's going to be 4 main clinical findings I want you guys to know for boards and life clinically. The tetrad for this is going to spell out, it doesn't spell out anything good. It would be SHA, S-H-A-A. That's the best I can come up with, guys. S would be severe rigidity. H is hyperthermia. A is AMS, which is altered mental status, and the second A is autonomic instability. This rigidity type with NMS is different than serotonin syndrome, as it is a lead pipe rigidity. No clonus, not a tremor, constant rigidity. Lab findings that you're going to find are elevated CK, leukocytosis, rhabdomyolysis, myoglobinuria, and acidosis. That is what you are going to see with NMS. So the treatment for neuroleptic malignant syndrome is going to be, drum roll again, please, stop the causative agent, stop the causative drug. We're stopping the drug. We're going to do ICU level supportive care, cooling measures for the hyperthermia, fluids, bromocriptine. So let's look up bromocriptine for neuroleptic malignant syndrome to see what the down and dirty of this pharmacology is for NMS specifically. So bromocriptine for NMS is used to help reverse the underlying dopamine deficiency blockade seen in neuroleptic malignant syndrome. So why it works. So NMS is caused by, we know, dopamine receptor blockade from those antipsychotics, from Reglan, droperidol, or sudden withdrawal from dopaminergic drugs like levodopa for Parkinson's. So the treatment can include restoring dopamine activity. Bromocriptine is a dopamine agonist, primarily D2 receptor agonist. It stimulates dopamine receptors that can help improve rigidity, fever, mental status, and that autonomic instability. So that is how bromocriptine works for neuroleptic malignant syndrome. What's the problem? The problem is dopamine receptors and dopamine blockade. How do we reverse that? We give a dopamine agonist in bromocriptine. Another medication that we can give is amantadine for NMS, is another medication used to restore dopaminergic activity in NMS, specifically when bromocriptine is not available, not tolerated, or as an adjunct to bromocriptine. So this medication works similarly in that it restores that dopaminergic activity, which is what we are looking to do. This specific medication, amantadine, is useful if bromocriptine causes hypotension, if we need another dopaminergic option, if Parkinsonian's features are prominent, or combination therapy is desired in severe cases. So can be an adjunct or can be frontline depending on what we have going on, but I want you guys to know that the main treatment for NMS is that bromocriptine, because that is important to know. Other things we can do is dantrolene may help rigidity. So dantrolene would be back shelf pharmacology in terms of giving it. The anesthesia pearl here is avoid Reglan and droperidol in patients with neuroleptic malignant syndrome history. I've never seen it clinically speaking, but it just depends on what patients come your way. So for malignant hyperthermia, let's dive into the next differential diagnosis. What is it? So this is a true anesthesia emergency. I've discussed this with my students ad nauseum. We've talked about malignant hyperthermia. MH is a genetic calcium handling disorder of the skeletal muscle, most commonly due to mutation in those, everybody say it together, RYR1, right? Less commonly is the CA1S, also a genetic mutation, but these mutations allow uncontrolled calcium release from that SR, sarcoplasmic reticulum, in the skeletal muscle, right? The triggers, as we know these well, right? Two major ones are our volatile anesthetic agents and succinylcholine, not propofol, not opioids, not non-depolarizers. Super important because if on boards you get a question, which one of these can cause MH? If it's a bunch of inhaled agents and succinylcholine, and then you have fentanyl. Fentanyl is clearly the one that you can give to these patients. Nitrous oxide is one that people like to throw into multiple choice questions with these triggers to kind of trip you up. These patients can receive nitrous oxide. They just need to have an anesthetic machine that's been washed out. But again, I've talked to my students about that a million times, and we can do another lecture for that on another day. What happens? Calcium floods the muscle, right? Then you have sustained contraction, ATP depletion, CO2 production rises, O2 consumption rises, heat rises, acidosis, hyperkalemia, and rhabdo. The first sign of all of this is, everybody knows this, that's getting close to taking the C or taking boards, right? Rising end tidal CO2, not the fever, and this is very heavily tested. The first thing you're going to see is a rising end tidal CO2. I've seen this intraoperatively, and you're going to be increasing ventilation, and the end tidal CO2 is not going to come down. Other differential diagnoses that can cause an increase in end tidal CO2, where you're thinking maybe this is MH, and it ends up not being, is a malpositioned trocar in the abdomen with the CO2 pneumoperitoneum. If you have a malpositioned trocar, not you, but the surgeon has a malpositioned trocar, you can get that subacute emphysema, right? You can get CO2 accumulation underneath in the adipose, underneath the skin, and that can actually cause increased end-tidal CO2. That is hard to get it to come down with increased ventilation because it's actively being absorbed, right? So that is another differential diagnosis I wanted to share with you guys. With a consistently rising end-tidal CO2 and you're like, what the heck is going on? Is this MH? Sometimes it could be maybe a pneumoperitoneum issue. So the clinical findings for MH early is that rising end-tidal CO2, tachycardia, and rigidity. Late signs are hyperthermia, ironically enough. By the time you're trying to figure out what's going on, the temperature is rising. Anemia, Coca-Cola urine, dark urine from the rhabdo, right? And CK elevation and arrest. Arrest is always a late sign. Oh, not always, I guess, but arrest is the late sign here. So treatment, number 1, everyone says it together, stop the triggers. A 100% oxygen, hyperventilation, dantrolene 2.5 milligrams per kilogram IV. Repeat that as needed. Cooling treatments, ice packs right in the axilla and groin. Treat potassium and acidosis, hyperkalemia and acidosis, and ICU monitoring. Dantrolene saves lives, but in MH, but it is not the primary treatment for serotonin syndrome, as we discussed already. So I have this chart here, and if you're watching, I'm going to throw it up onto the podcast YouTube, that you can look at this quick little chart that talks about the differentiating between the trigger, onset, reflexes, end-tidal CO2, rigidity type, and the best drug for all of these different differential diagnoses between serotonin syndrome, NMS, and MH. I'm going to wrap this up really quickly. I did have a clothing change if you are watching this on YouTube because I'm finishing up this podcast on a different day, okay? But same me, different day. To wrap this all up, let's summarize it. Let's get down to the board's questions that they love out of these 3 topics, these 3 differential diagnoses, okay? If the end-tidal CO2 is suddenly rising under sevoflurane, we can think MH. We can keep that on the top of our differential diagnosis. If the patient is on sertraline or Zoloft, gets clonus and agitation, we think serotonin syndrome. If psych patient is on haloperidol or Haldol, gets a fever and rigidity over 2 days, we're thinking NMS at that point. If unsure, we ask what drugs were given, how fast did it happen, clonus or rigidity, and end-tidal CO2 elevated or not. Seeing these in person is pretty rare. However, knowing how to distinguish one from the other is important clinically, but also for boards questions. All right, my favorite learners. This is one of those topics where memorization is not enough. You need to recognize patterns, and when the room gets hot, your heart rate rises in the patient's, and the patient looks toxic, we've got to ask ourselves, is this a serotonin problem? Is this a dopamine problem? Or is this massive calcium crisis? We have to know the trigger, know the timing, and know the treatment. I'll see you on the next episode. Hello, my favorite learners. This podcast is for educational and informational purposes only and does not constitute medical or professional advice. While we strive for accuracy, medicine is constantly evolving, and clinical decisions should always be made based on current guidelines, institutional policies, and individual patient considerations. The views expressed are those of the host and guests and do not necessarily reflect the opinions of any affiliated institutions. Listeners should consult their own healthcare providers before making any medical decisions.